Kalpesh, can we go live? Can we go live? Yeah. Good morning to all the guests from the USA, and good evening to the Indian faculty and the participant from India. I welcome you to this webinar um, on a Glenn Preminger Stone Prevention Clinic inauguration. This is on occasion of that we are going to have a seminar on stone prevention, and I just would like to give you a little history behind this. As you know, that the stone is a global and incidence is increasing, and the size is decreasing. It is a recurrent disease. It can destroy the kidney, associated with high morbidity, if not mortality. No age is immune, no sex is immune, no race is immune, and no region is immune. And for last 42 years, we've been treating stone with a new modality, and we have done 31,000 stone treatment, and we have adopted all the newer modality. And so we are prepared to treat the stone with the best of our ability, giving them a stone-free status. And Kalpesh. And what we find that the majority of the stone has become stone, and stone has become smaller, and majority of the stone has is less than a 3 centimeter. But stone incidence is increasing and stone size is decreasing over the last 42 years because of the awareness of the modality of the stone. For example, this is what type of stone we get. I would like to show you and share with you. This is a 62-year-old male with multiple stones in the right kidney, and this is the IVP. And we asked him to get it done, and he came to us in '96 again, and then he refused to have the treatment, and then the stones all came down into the ureter, and then he came for the surgery. We did a ureteroscopy and a PCNL, and then completely cleared the stone. And then again, the stone recurred in the lower calycis. And then he again refused to have a surgery. And in 2007, he came back with a stone dropped into the ureter. Almost more than 12 years history of the stone. And this time, we did a renogram, and we found that the right kidney is not functioning. So here, the stone is recurrent. Not only recurrent, but the patients, they are loan compliant. So unless and until you completely clear the stone and then have a prevention, there is a good chance that you might lose the kidney. And during 1999 and 2000, I've been attending AUA all the time, and then I heard Glenn Preminger talking about the ureteral sheaths and the flexible ureteroscopy, how safe the flexible ureteroscope. Till that time, we were doing PCNL all the time. So we invited Glenn Preminger to Nadiad for the West Zone conference, and he demonstrated the sheath and the flexible ureteroscope, and it was really a good operating workshop, which stimulated lots of people in picking it up. Ever since then, Glenn became a friend, and he came for the Joe Sugura course, and then along with it, he was many urologists who were interested in stone, they came to Nadiad and we had lots of discussion, and we realized that treating the stone is one thing, but preventing the stone is another thing. And then we become a friend, and then we've been discussing many aspects of the treatment. And Jody was one of the really encouraging Glenn to help us out, and he was the most popular teacher among our residents. And he had many conferences in Nadiad. And this is a Glenn and Jody. This is a geosurgeon, and during that time, they decided to adapt our hospital and give us a very handsome donation to start the prevention of the stone. And this is where we both were discussing how you can prevent the stone, and that's how the genesis of the department which we are going to start, which is going to take care of the stone treatment. And Glenn, we are very happy that not only you stimulated us to start a department, but you also going to transfer the knowledge. And Rohit Bhai, our chairman, has given a big thank you to you for this kind gesture. And as you know, the Glenn Preminger just finished as a president of the World Endocrinology Society. And unfortunately, we could not have the annual conference. But Glenn, you started something this year. There are so many webinars, so many things. Every week we see on a different topic, small topics. And then we are getting better knowledgeable. And the students are finding it very useful. You have plenty of honors and awards, and you had a publication more than 322. You are a great teacher, and we really admire you at Nadiad. David Goldfarb is the chief of nephrology, and he was a president of the research on the Calculus Kinetic Society, the Rock Society. And I was interested in Rock Society because they focused on the stone prevention and how it can be done. And then with Glenn and David, they all came down to Nadiad, and we had one meeting of Rock Society in Nadiad. How did a nephrologist get involved into the calculus disease? It's very interesting. And his own word, he says, after a difficult personal experience with a kidney stone that required a shock wave treatment, I resolved to take care of my fellow patient. I knew the condition was interesting and often neglected, and I felt I needed to do something about it. And my background in physiology meant that I was well prepared to study the kidney stones. David, I just read your article, Empirical Treatment for the Kidney Stone. Very often we don't find anything. And then you have described how to manage the stone in this situation. Roger Schur has been a professor of urology at University of California, San Diego School of Medicine, and our interests are common. And earlier last year we were together in Nadiad, the dusting and sucking the stones out, and his research is phenomenal. His insight in this thing is great, and very shortly we'll be seeing his invention in the market. Roger Schur, welcome to Nadiad again. Brian Eisner, you inherit our relation with the Boston Mass General. Steve Detler, who was one who put us on the new modality, especially the ureteroscopy, and you have joined us, the legacy of him, and you've been interested in the kidneys, in the stone disease, and you have also been to Nadiad, and you have been helping us with a new modality of treatment. Again, we are looking forward to seeing your presentation. Thank you, Brian. Dr. Subnis is chairman of our hospital, and he right from the beginning he's been interested in the stone disease, and he is though I've been concentrating on PCNL, he has been concentrating on flexible ureteroscopy, and then he is great hobby as teaching. and he has a multiple students who has gone through his. He was a chairman and he was honorary secretary of the Urological Society of India, and hopefully we'll see him as a president next year. And Pradeep Ganatra, he's going to speak on the environmental aspect. And Pradeep is my partner since 1982. And when I was practicing in Ahmedabad and coming to Nadiad, and he used to take care of my hospital in Ahmedabad. I don't think without him, I would have been able to do anything. And Pradeep has got a beautiful, intuitive mind, and he has collected all the data. Whatever work we used to do, he used to collect the data and he used to analyze it. Pradeep, thank you so much for taking part in this. And now I would invite Roger Sur to give his talk on technique of stone composition.
Good morning, Mahesh. Thank you so much. I'm really honored to be a part of this lecture series, and as a former student of Glenn's, I really want to thank him because really I'm here because of him. Let's be honest. Could you forward my slides because I don't have control, Mahesh? I'm going to be talking to you this morning about stone analysis, which is an aspect of stone disease that really at least in my practice, we don't focus a lot on the actual techniques, but in reality, this is an important aspect of stone disease workup because it really can affect your interpretation. And I'll explain why here in a little bit. It's not to say that 24-hour urine is not important, but the stone analysis and how we get the stone analysis is a critical portion of the workup for patients, and it can affect your ability to prevent their stones from recurring. Next slide, please. These are my disclosures. Next slide. So in essence, there are 4 ways that your lab can perform a stone analysis: X-ray diffraction, Fourier transfer array, infrared spectroscopy, polarization microscopy, and wet lab or chemical analysis. Next slide, please. So X-ray diffraction, what is X-ray diffraction? This is actually thought to be one of the more accurate ways to perform a stone analysis. So if your lab does this, kudos to them, and you can feel confident that you're getting an accurate description of the stone. What happens here, as you can see in the bottom left, is an incident X-ray energy is incited, hits a stone, and depending on the stone composition, different angles come off from the stone. And from these patterns, different stones create different patterns, and from the pattern, then the lab can determine what type of stone has been created. The EAU supports the use of X-ray diffraction given its accuracy. As an example here, you can see at the bottom, this is a diamond, and this is graphite. Graphite and diamond both share the same chemical structure. They're C4. So we think, well, if they're both C4, how come one is only a rock and the other one is something that we all want so badly? Well, with X-ray diffraction, what we see is that the diamond actually is a structure that looks like this, whereas in a graphite, it's actually a planar structure. So X-ray diffraction is really able to kind of break down and give us a true 3D dimension of what a structure looks like. Next slide, please. Polarization microscopy. Well, what is that? Actually, you're probably familiar with this because if you have a nice pair of sunglasses that are polarized, so to speak, they're lined so that they only permit a certain angle of light to come through, as you can see here on the left. If there's a light source here going through a polarized frame, only certain aspects of the light are coming through. And if you have another frame that's below it, then and it's lined up in the same way, all the light comes through. However, let's take that same light source, put it through the same frame. So like we said, only one light source comes through, but then take the second one and turn the frame, let's say 90 degrees. Now we know that these two are not aligned, and therefore the light does not go through. And that's what the concept of polarization is. And so what your lab will then do is take a stone, which is birefringent or can actually create different angles when the light is incident to it. And so in the same model, the light comes through a polarized frame, hits the stone, and creates all these different angles. And some of those angles will actually make it through the second frame that's been turned. And with this pattern, we can then describe what type of stone you have. Next slide. The problem with polarization is that it requires a significant amount of stone material. So if you have a tiny little stone, it may not be useful. It's also heavily operator dependent. Mixed stones cannot be identified. And so there are some limitations to this technology. Next slide. Chemical analysis. This is the most widely used technique. It detects individual ions. So as opposed to the whole picture, you're only looking at individual ions. So it's kind of like the whole concept here. You're missing the forest for the trees. You're focused on the trees, but missing the whole forest. And so it has the potential to really make significant errors in interpretation. Unfortunately, it's the most widely used technique throughout the world, but also the most inaccurate. So if your lab uses wet chemical analysis, there is a strong chance that you might have a misinterpretation of the stone or not even detect a stone. For example, let's say you have a rare uric acid stone, which can be treated very specifically, right, and successfully, but with wet chemical analysis, there may be a misinterpretation, and you may never know that you actually had a uric acid stone. So this is mentioned only to be avoided if possible. Next slide. So really briefly here, I'll end up my lecture. What if you don't have a stone analysis, the ability to do that? Well, if you've been treating stones for a while, you probably are familiar with different types of stones. So I think what can be helpful is for us to teach our students what different stones look like. And not to say that it should replace stone analysis, but it may be, at least as a backup, something useful to have. Next slide. Let's go through a couple stone morphologies and I'll end my lecture. Next slide. So this is the classic calcium oxalate monohydrate. It's that kind of really hard stone that doesn't like the dust. It's you have to really increase the pulse energy to break it up. So this is something we should teach our students, that the dark brown, next slide, stone is the calcium oxalate monohydrate. Next slide, please. This is the classic calcium oxalate dihydrate stone. It's kind of a beautiful stone in my mind. It's very brittle. It's typically associated with hypercalciuria. So that's something to keep in mind, that should you have this type of stone, recognize statistically there's a high chance that the patient is suffering from hypercalciuria, so you might want to consider using a diuretic. Next slide. These are, on the left is a monohydrate, on the right is a dihydrate. The point being that there are different phenotypic or different appearances to these stones. Next slide. Uric acid, this is the classic kind of golden yellow stone. You see this, you know you can now just treat the patient by alkalinizing them, and you might be able to dissolve the stone or definitely prevent the stone. Next slide. This is the classic renal tubular acidosis appetite stone. Next slide. Lemon cysteine forming stones, rare, but should be recognized. And I think that's my last slide. Next slide. Yep, that's it. Well, anyway, I've given you a very brief summary of stone analysis and its importance, and I hope you can utilize this in your practice. Thank you.
Mahesh, I think you're on mute.
Okay, thank you very much, Roger. It is a very nice talk, giving the basic structure of the stone and how we can identify. I think nowadays the endoscope is so good that you can identify the stone, at least guess nearby that what type of stone it is. I think the question we will take at the end of the session. Now I invite Brian for talking about the international variation in the stone composition. Brian?
I see my slides? Okay. Yes. So, Mahesh, the first program I got said that, but the new and updated program said that I was supposed to speak on environmental factors in stone formation. So that's what I wrote my lecture on. I think one of the things I would say is, it's a true honor and privilege to be here. And, I think, Mahesh at the start, in addition to saying very kind words about all of us, outlined, the endourological collaboration, a long friendship between him and Glenn that's involved many, many other people in those circles and really created progress in stone disease. And, as many of you know, we lost the great Dr. Drettler last year, but I would say that I think if he was looking down on me, which I hope he is, seeing me on this panel and seeing what you're doing here for education and progress for stone disease, he's certainly smiling. So thank you for this great honor. It is quite a privilege to be here with luminaries in the field. Let's see. Here are briefly my disclosures. And so if we're going to talk about environmental exposures, I'm going to introduce a term. Actually, the first great lecture I heard on this term was by none other than David Goldfarb. But this concept called the exposome really is about people's exposures in healthcare and how it affects their health. So this was first defined in an epidemiology paper by a gentleman named Wild. And the exposome is the totality of exposure of individuals' experience over their lives and how these exposures affect health. And what I'm going to focus on is several different types of exposures that have been looked at and how they may affect kidney stones. This is by no means comprehensive. You see what's starred here, and part of the reason I did that is that many of the other things are, I think, very well characterized and studied, but the ones with stars, I think, perhaps there's still kind of room to study, but I'll sort of tell you kind of how I view this and how it all comes together. So I'm going to start with weather and climate. Of course, everybody knows that dehydration is a risk factor for kidney stones, but if we dig a little deeper, I think we may see some interesting trends. So this is, I'm going to start with the systematic review published in 2017. This was a review that simply looked at the impact of warmer seasons on renal colic and kidney stone disease. This is by Dr. Traxair's group and Somani. They evaluated nearly 60 studies and about 13 met criteria. And of those 13, 12 studies demonstrated a significant relationship between temperature and renal colic events. Now, many people simply assume this is due to dehydration, but I'm going to sort of ask the question rhetorically. We all know that stones don't form overnight. So to say that the summer months are hotter and that's why people get renal colic doesn't quite fully explain this phenomenon to me. And I would just sort of pose the question, maybe later on someone may take it, but if stone formation takes months to years, why are the warmer months associated with greater number of stone events? I understand they may be associated with greater risk of stone formation, but is there something about heat that not only adds to stone formation, but also perhaps creates that crack in that single crystal that attaches the stone to the papilla and perhaps induces stone passage and colic events? I have always been interested in concepts of what other than dehydration may increase risk for stone formation. This was a study that was early on in my career where we looked at 24-hour urines from 4 sites. And we specifically picked these sites because they represented some geographic diversity in the United States. So you see that 2 of them were in the Northeast United States. That was us, and then Dartmouth with Vernon Pace. 1 in the South, that was Nicole Miller at Vanderbilt, and 1 in the Southwest, which is Mitch Humphreys in Mayo, Arizona. And what we noted, no matter what the location, was that increasing temperatures, in addition to being associated with lower urine volumes, which we know, were also associated with increases in urine calcium excretion and supersaturations of calcium oxalate and calcium phosphate. These findings were independent of both location and climate. And interestingly, we didn't find any associations with humidity. So really the driver seemed to be here that the hotter places, in addition to having people with lower urine volumes, also for some reason demonstrated a higher urine calcium excretion, another risk factor for stone formation. So again, maybe some some indication that environmental factors may be actually changing people's physiology. This is a paper which I thought was quite interesting. It's actually a hypothesis of Dr. Goldfarb's and his colleague, Jacqueline Hirsch, who have been very thoughtful about what places are hotter and what places are not. And so what they describe in this article, which is something well known in concepts like urban planning, but less well known in medicine, is the concept of urban heat islands, or UHI. And what we know is that urban heat areas are areas, or urban heat islands, I should say, are areas with elevated temperatures. These places are hotter in the daytime and far hotter in the nighttime than surrounding rural areas. And what you can see here in the cartoon, for example, in the lower left, is you can see warehouse and industrial locations and also downtown urban locations demonstrate higher surface temperature at both day and night than surrounding rural areas. What we've seen, of course, as Dr. Desai starts talking about the last 42 years, is a massive shift and continued urbanization globally. And with continued urbanization, of course, many more people are exposed to these urban heat islands. And I think Dr. Goldfarb raises a very interesting hypothesis here, which is, can increased urbanization with increased people closer to these very, very hot areas in large, crowded cities, could these be contributing to the increase in stone incidence and prevalence that Dr. Desai talked about when he kicked off this lecture? So I think more to come. I think it'd be very interesting to know what 24-hour urines look like near these heat islands, but certainly very interesting concepts. And of course, especially a resident with Dr. Goldfarb, who lives in New York City, which probably is the place of greatest heat islands in the United States. Another very interesting sort of theoretical paper, this came out of Peggy Pearl's group actually over 10 years ago. And what they did was they created some mathematical modeling of global warming. Now, in the United States, we consider the areas of highest stone risk, we call that the stone belt. And as you can see, in 2000, the stone belt is all the yellow areas. And what Peggy Pearl's group did, based on this upper left corner where they are hypothesizing about increases in global warming and increases in global temperature, is they then modeled out what it may look in terms of increases of stone incidence and prevalence. And what you can see is that their prediction is that whereas in 2000 the stone belt is the yellow states, by 2050 the stone belt will include much more states kind of moving north, kind of the Midwest and middle of the country, as well as the entirety of California. And by 2095, even the red states. And so you see that the stone belt, based on their predictions in the United States, based on these global warming predictions, is going to increase from, a third of the country to close to half the country. So perhaps more business for stone surgeons in the future, but also for stone preventers in terms of the trying to counteract the impacts of heat. I'm going to shift a little bit from climate to occupation and work. And I'm first going to talk about a study actually from steelworkers in India. And the hypothesis of this study was that high occupational stress and a heavy workload, as in the manufacturing industry, will lead to dehydration and rise in body core temperatures, which will lead to stone formation. These are logical assumptions, but I think very important to understand what the public health impacts are based on the number of people that are in these jobs. So this was a cross-sectional study of 340 steelworkers in India. And what they did in self-reported questionnaires, they noted that 95% of their workers demonstrated significant symptoms of heat strain, dehydration, and body core temperature in their daily factory jobs. And they also noted that of the workers that had over five years of heat exposure, these were the workers that had the greatest risk of renal calculus formation. So maybe this is obvious that if you work in a hot, stressful environment, that you're at risk for stone disease. But I think as we understand more and more of these populations that are at occupational risk, perhaps we can put preventative measures in place, like mandatory breaks for drinking, or even consideration of perhaps different kinds of diets or ways to increase things like urine citrate or lower other urinary risk factors. Perhaps focusing on these real at-risk populations may change the incidence of stone disease in the future. Another very interesting work by Dr. Goldfarb and also many of our good friends, Oja Shah, now Columbia, is the concept of occupational hazard based on patients who may not be able to urinate frequently. So they review in their article a actual theory by Lally and Lapidis that was first propagated in 1969 called the infrequent voider syndrome. And these are people that void with less than usual frequency, and this can result in the development of infections, renal failure, and I think what's implicit is perhaps dehydration and stones. What Dr. Goldfarb and Dr. Shaw did was, of course, they took this theory that was many, many years old and applied it to, modern times. And, the classic example is the taxi cab drivers in New York City, and what is very true is these taxi cab drivers have very little access to bathrooms. Therefore, many of them deliberately dehydrate themselves. And of course, we know that deliberate dehydration in general creates a risk of stone formation. I just created, the taxi drivers are one example, but we can see many. I remember that when they were building our cancer center, for 2 years out my office window, I saw gentlemen standing on the scaffolding building the building. Again, poor access to the bathroom. I'm sure intentional dehydration, and perhaps these patients are at higher risk for stone disease. I'm going to shift briefly to genetics and environment. Again, Dr. Goldfarb, really a pioneer in this group. Hopefully you'll have good things to say about this talk when I'm done. But this was an earlier study, again, almost 15 years ago, where they looked at male-only twins. And I think what you find here is actually very, very interesting. What they find, of course, is that among identical twins or monozygotic twins, if one twin has a stone, there's a much higher likelihood than that the other twin has a stone than among dizygotic twins. So monozygotic or identical twins are more concordant for stone prevalence and incidence than dizygotic twins. And what this shows is that there's a specific calculation the geneticists perform, which shows they predict a heritability. So they say in this paper that 56% of stone disease is heritable. And to me, this means two things. There's a strong genetic component, but clearly the genetics only explain about half of this disease. And therefore, there also must be a strong environmental component. And so I think just goes to show that both genetics and environmental exposure play a very important role in stone disease. What I really love about this group's follow-up paper, which is much more recent, is that they have the opportunity to look at a different twin registry and study both males and females. And what they found here was that the heritability of stone disease was actually stronger in men than women. So both have strong heritability, but again, the heritability and environmental impact are different from one gender to the next. And so while kidney stones are heritable in both genders, it looks like females may have a stronger environmental component, although the males still have a strong environmental component. So again, kudos to Dr. Goldfarb for really kind of pushing through these concepts of both the strength of genetics, but also the equal strength of environment in determination of stone risk. And then prior antibiotic use, I think that there's been a lot of very interesting work in this field. We all know that antibiotic use alters the gut microbiome, which can in turn change things like the presence of oxalobacter and in turn urinary oxalate in the body. This is an epidemiologic study. I think everybody knows this group, Gary Curhan, Eric Taylor, their Italian colleagues. They looked at two large cohorts of females that were followed for over 20 years with over 100,000 participants, and they also had a subset of 5,000 24-hour urines. And what they found was that the cumulative use of antibiotics for over 2 months in one's lifetime was associated with a significant increase of risk of kidney stones of about 30 to 50%. They had a weak signal that showed that perhaps some of the pathophysiology was lower urine pH and lower urine citrate. But of course, in these big epidemiologic studies, we often define a relationship without understanding the cause. But for what it's worth, they hypothesized that perhaps this is alterations in gut flora, but perhaps it also may be alterations in renal tubular physiology. I'm going to end on socioeconomic status. So these are studies from the United States, 2 studies that came out of our group and also with Vernon Pace, who many of you know. We were interested in understanding the different disparities in stone disease that may segregate with disparities in socioeconomic status. We looked at over 400 patients from 2 clinics, both a rural and an urban setting. And what we found was that lower socioeconomic status was actually associated with higher urine calciums. Lower education level was actually associated with higher urine calciums. And in the US, what we would consider unfavorable insurance status, so these are people who are able to afford sort of the lowest levels of insurance, were actually associated with increased risk factors for calcium phosphate stone formation, including higher urine pH. And we know that sometimes these calcium phosphate stones are very difficult to treat. So just some suggestion that at least in the United States, it does appear that people that are less well off financially may be also disadvantaged in terms of risk of stone formation. So I think what we see here, and to summarize, is that there are many different exposures that can contribute to the kidney stone exposome. And again, I do want to thank David for introducing me to this topic in his lecture at the Rock Society several years ago. And just some that I touched on today are climate and weather, occupation, genetics and gender, antibiotics, and socioeconomic status. I think historical research is focused on one exposure. How does working in a steel factory affect stones? How does gender affect stones? And I think what we really need to do, of course, it's the most difficult thing to study, is understand the interplay and understand where all of these intersect so that we may best be able to kind of divert our resources and focus to kind of attack the most important problems. So again, this is my beautiful family, and this is my, I'll call it my kidney stone family. This is obviously Roger, myself, Dr. Desai, and Preminger, and Nadiad. And of course, every time I travel and think about stone disease, Dr. Goldfarb is always with us. So perhaps he'll make, as a uronephrologist, he'll make the next trip to Nadiad. But again, just thank you to Dr. Desai. It's such an honor to be here. And I'm certainly humbled at the experience of being able to present. So thank you so much.
Brian, this is brilliant. Thank you so much. You have given us lots of insight where we can focus our research. India is a big country and we have lots of stone, but we have to find the backlights. And that was a brilliant talk. Thank you so much. And I love that. Now, on a similar line, Pradeep Ganatra has been working because we have people coming from a certain area with the stone, and then we try to look for the metabolic abnormality. But as Brian has suggested, similar things are present. I want to look at our data, and Pradeep is going to show that. Pradeep?
Yeah, thank you very much. Greetings from Nadiad. I'm thankful to Dr. Mahesh Desai for giving this opportunity to speak on a subject which is very close to my heart. How far the environmental factors are responsible in the stone formation. This is more of a study done at the local level at our hospital. During the 3 weeks lockdown period, I had the chance to read many articles. Ones that interested me most were the role of hot climate and hot occupation leading to chronic dehydration and thereby playing a role in the formation of genital stones. Also the role of temperature with humidity which varies round the year and its importance to the seasonal colic attack. During this, take this example. I took a randomized samples from the year 1990 to 2019. What I studied was 1,336 cases where male comprised of 70% of the stones. The age in which it was frequently seen was between 40 and 60, both in males as well as the female population. The residential location of the patient were noted, and the parameters studied were temperature in Celsius, humidity in percentage, atmospheric pressure in hectopascal. This data was collected from the website of timeanddate.com. The idea of fixing the date of 15th May 2019 between 12 and 18 hours was to standardize the reading. Also, this being the peak of summers in almost all parts of India. Other factors that were noted were latitude, longitude, and altitude. This information was retrieved from Wikipedia and the website of Map of India. It was observed that 82% of the patients were residing where temperatures were between 36 and 40 degrees Celsius, or what we say in Fahrenheit, 96 to 104 degrees Fahrenheit. Similarly, it was also observed that 45% of the patients were staying when the humidity was between 30 and 40%. Interestingly, it was also seen that 89% of our patients were residing between a latitude of 21 to 25 degrees north. Also, it was surprising to note that 61% of the people were residing within 500 feet above the sea level. All the above findings led me to study different permutation combinations. 69% of the study group stayed at temperatures between 36 and 40 with the humidity range of 20 to 40%. When we analyze the relation of patient staying between temperature of 36 to 40 and latitude of 21 to 25 degrees north, no, it was 77% of the people were staying in this area. Again, the relationship between temperature and altitude revealed that 50% of the patients were located in the range of 36 to 40 degrees Celsius and within 500 feet above the sea level. Similarly, humidity and latitude showed 70% and 43% within the mentioned humidity and altitude range. 56% were seen residing within the range of this latitude and altitude. So, all in all, when the three factors were considered, temperature of 36 to 40 degrees, humidity of 20 to 40%, and latitude of 21 to 25, nearly 67% of our patients were found staying located in this set of parameters. If we added altitude of within 1,000 feet above the sea level, it was observed that 50% of our patients were staying within this criteria. Now, how does this figure help us and the data help the clinical scenario? The way forward to go would be to have more numbers to substantiate the observations and to study the relationship between urinary metabolic study with the said environmental factors. We also need to check whether there is any variation between this finding vis-a-vis a low risk and a high risk zone forms. Also, an American study showed the role of atmospheric pressure in conjunction with temperature and humidity, and its observation was it was observed that there is an increase insensible loss of fluid in the set of combination. We need to try and relate this, whether it embraces and any loss or change in the urinary volume output. Latitude of being between 21 and 25 degrees north in our batch of study would be of interest if found across the globe. Therefore, in order to achieve more and more information like environment and electrolyte should be attempted with to see whether there is any relationship. In a country like India where 4 seasons are seen, it would be very informative to see if there is any change because of this variation. Also, we have observed before 30 years, most of the population of a particular village were inflicted with genitourinary stones. We have not seen the same recently. It would be very enlightening to see whether this change has happened, if at all. Is it the climate change or is it the change in food habits or the drinking water content? Also, we say bladder stones are passive. Is it really so? Also interesting would be the role of nutrition and diet, especially in the pediatric population. As Brian said, the progress in genomic studies and molecular studies are also being attempted. So, the point to make is the role of environment and geography is surely not a myth. If such incidences and if such studies with the starting of stone prevention clinic, the agony and pain of the waiting people like this can be alleviated, it would be hard work worth everything. Constructive contributory creativity to bring about the winds of change to build a better future is always very satisfying and blissful. Thank you again very much for this opportunity, and it would be a pleasure to receive comments and guidance from the stalwarts and interested scientists of the field of this vast, open, less tapped avenue of this unfathomable giant. I would like to see those winds of change. Thank you very much.
Thank you, Pradeep. It was very nice, and you have taken lots of pain to collect this data. I just would like to ask Brian if you have any comment on this data, because you also had collected the data, similar data in USA. Do you have a comment on this data?
No, I mean, I think the idea, Mahesh and Pradeep, and I totally agree, of course, is that, let's face it, we are from very different parts of the world, right? And I think that what we need to do is understand both the physiology and how it relates to, our local areas. And, it's funny, when I worked with Dr. Stoller out in California, they had a very large Asian American population there. And when I looked at Marshall's patients, for example, what I found, and it wasn't the best study in the world, but what we did find was that if we compared the Asian stone formers, these are mostly Chinese Americans and Japanese Americans, with the Caucasian stone formers, we found they made stones for different reasons. We found hypocitraturia was a far more common problem, among the Asian stone formers. And, whereas hypercalciuria and hyperoxaluria was far more common among the Caucasians in that group. And so I think that the big picture is analyzing our local, patients and our local problems is the key, because as we know, it's not sort of one disease. We all sort of come from different genetic pools. And of course, even here, Caucasian is even a very heterogeneous, kind of comment, if you sort of think about what makes that up. So certainly I think, with your huge database in Nadiad, evaluating all this stuff is only going to help us understand better the pathophysiology of this disease in general and how it relates to the people that come see you there.
Thank you, Brian. Now I'll come to Glenn. I invite you, Glenn, to talk on can you use the stone composition alone to direct the medical stone management? Glenn Preminger. Then you are mute. Unmute yourself. પછી મારું છે અવાજ આવતો નથી. Glenn, can you unmute yourself? Glenn, now you can unmute करा नहीं. Okay, Glenn, you can speak.
Well, thank you, Mahesh. And first, I'd really like to thank you and the Nadiad team for putting this together. And I'd also like to thank you for all of your focus on stone disease over all these years. And most importantly, that you, as a urologist, are still completely committed to metabolic stone management and how important that is for our patients. And I think that as urologists, we really focus on stone management, mostly surgical, but we also have to take that into account. And so putting together this program today, I think, helps to emphasize the importance of not only taking care of the patient's discomfort and well-being from a surgical standpoint, but also having the ability to identify underlying risk factors and have that patient treated appropriately. And I'd also like to especially thank Brian and Roger and David for participating today because of their efforts. We again promote appropriate stone management. Here are my disclosures. So there's no doubt that the role of stone analysis has probably been neglected and underutilized, mainly because comprehensive metabolic evaluation and selective medical therapy has been shown to be an important stone disease. And so, again, the purpose of this whole session today was to focus on stone evaluation or looking at stone composition and how we might use that. So what I'd like to focus on to see today, if you can use stone analysis by itself to predict the underlying metabolic problems in our patients with nephrolithiasis. And so the bulk of this talk is based on a study that we did a number of years ago, which was to assess the correlation of stone composition with specific metabolic disorders and to determine whether stone analysis can offer reasonable assessment of metabolic abnormalities and offer treatment guidelines for these patients. So we did our stone analysis through the LabCorp laboratory in the United States using optical crystallography. And we used the predominant crystalline composition of stone interior to determine primary stone composition. We investigated 100 consecutive patients where we had both a stone analysis and an ambulatory comprehensive metabolic evaluation at our Comprehensive Kidney Stone Center. We used standard metabolic diagnoses listed here that included both calcium-containing and non-calcium stones. And basically, these patients broke down to 62 males. The majority of these, 90%, were white, and only 11% non-Caucasian patients. And what we found when we looked at the overall composition of these, the stone composition in these 100 patients, was that 74% of them had calcium stones and 26% non-calcium stones, which goes along with what we see in all the large epidemiologic studies. And interestingly, when we looked at the underlying metabolic diagnosis as determined by the comprehensive metabolic evaluation to the stone composition, we found that comparing calcium oxalate now to calcium phosphate stones, a significantly higher incidence of gallodiathesis, defined as being a low urine pH, in our patients with calcium oxalate stones, and a higher percentage of hyperparathyroidism and renal tubular acidosis in our calcium phosphate stone formers, because the majority of patients with calcium phosphate stones have a very alkaline urine. There would be no surprise that you would have a higher incidence of RTA and hyperparathyroidism. When comparing uric acid and struvite stones, gallodiathesis is defined as a low urine pH. And so again, since 99.5% of patients with uric acid stones, low urine pH will be the primary cause. Essentially, all of our patients with uric acid stones had gallodiathesis. But interestingly, in our struvite patients, a large percentage of our struvite stone formers also had either low volume, hypocitraturia, hypercalciuria, or hyperuricosuria. But also remember that not all patients with struvite stones have pure struvite stones. And so we believe that the patients that have mixed struvite and calcium stones are probably the ones that have the higher incidence of metabolic problems. In patients with cystine stones, no surprise that 100% of these patients had cystinuria, but also note that 2/3 of the patients with cystine stones also had hypocitraturia, and half of these individuals had low urine volumes. So if we look at the role of stone analysis and can we use it to predict the underlying metabolic problems in our stone formers, we could recommend that if the stone composition comes back calcium oxalate, we could perform a a urine or a serum calcium study to rule out hyperparathyroidism, do a 24-hour urine calcium in these individuals, trying to differentiate between absorptive hypercalciuria type 1 or type 2. But note that 98% of our patients that had calcium oxalate stones also had low urine volumes or a condition that would require alkaline therapy. So we could say that combination of increased fluids and potassium citrate should be administered to all of our calcium oxalate stone formers. In the patients that had persistently high urinary calcium after being placed on a calcium-restricted diet, these patients would receive thiazide diuretics to lower their calcium. With calcium phosphate stones, we would again look at serum calcium to rule out hyperparathyroidism, check a urine pH to rule out renal tubular acidosis. Again, do a 24-hour urine to see if the patient would require thiazides, and place all of these patients on potassium citrate and possibly allopurinol if they had high urinary uric acid levels. For non-calcium stones, the results are, or the suggestion is actually quite simple. For all of our uric acid stone formers, we would place them on alkali therapy to counteract the gatodiathesis. For all of our cysteine stone formers, we could use a combination of thiola or D-penicillamine plus alkali in the form of potassium citrate. And in our patients with pure struvite stones, we would probably just treat these with antibiotics alone. But with a mixed struvite and calcium oxalate stone, a comprehensive metabolic evaluation would be warranted. There are limitations to using stone analysis alone to treat our patients. This data or these suggestions are based on only a small series of patients. We used optical crystallography versus infrared spectroscopy, and we used whole stones versus stone fragments. In addition, there are mostly heterogeneous abnormalities in our calcareous stone formers. We were not able to determine the presence of hyperoxaluria by looking at stone analysis alone, but you could argue that most of these patients are going to have enteric hyperoxaluria. So you would know the patient is hyperoxaluric if they have concurrent bowel disease or malabsorption. And we were not able to separate between absorptive or renal hypercalciuria using stone analysis alone. However, since we would use thiazide diuretics for both conditions, that should not be a significant limitation. So in conclusion, we were able to make treatment decisions based on stone composition in all of our non-calcium stone formers, which came to about 25% of our patients. And if you had calcium oxalate or calcium phosphate during the stone analysis, while you could not accurately predict specific treatments, but I think you can offer reasonable treatment guidelines based on a stone analysis and limited evaluation itself. So, in conclusion, I would offer that comprehensive metabolic evaluation still remains the gold standard in offering our patients selective medical therapy. However, stone analysis and limited evaluation may become a useful alternative, and that further prospective trials will be needed to assess cost-saving utility of stone analysis alone in the management of nephrolithiasis. And again, Mahesh, thank you for organizing and putting all of this together.
Thank you, Glenn. Thank you, Glenn. It was a wonderful way to do the medical, because we really need this knowledge. And then one thing is that you have very generously donated. But more important is we have going to borrow your knowledge in training our students in treating the stone. Now, I'm going to speak about the recurrent stone. 1 minute, let me get my slides. Okay. So last 42 years, I mean, one of the main disease we've been treating is a stone. And sometimes it is so painful to see the patient whom you have cleared completely and he walks back in your clinic with a recurrent stone. And then he undergoes. And this is a patient a long time back who has undergone a 3 times open surgery. So what is the natural course of the recurrent stone? Now I would like to share a couple of cases first, where this is a young boy of 20 years who had a history of open surgery when he was 6 years old. And then he came back with a multiple stone on both the kidney with a gross hydronephrosis. And we did a bilateral PCNL and completely cleared the stone. He came back in 1999 with again recurrence of stone in the lower calyces. And then, of course, he did not opt for the surgery. He waited, and in 2003 there was a growth of the stone, and again there was a residual dilatation. And then again he came back. I mean, he offered for surgery, and we cleared the stone by a PCNL completely. And then at that time we had come in contact and we started doing some analysis, and he was a calcium oxalate monohydrate person, and 48 hours urinary metabolic workup was hypercalciuria, hyperphosphaturia, and hyperuricisuria. This is another 28-year-old male with a history of right PCNL in 2008. In 2011, he had a bilateral stone. And again, we did a bilateral PCNL and completely cleared the stone in a couple of stages. And you can see in the end that he had a completely stone-free kidney. And again, in 2013, he recurred bilaterally with the small stones. And again, we went back and did a right mini perk with a 5 French ureteric and the left check RRS with a 6 French ureteric catheter. We left it behind, and then we cleared the stone. Again, in 2015, he has come back with the stone. And again, we have to do the right PCNL and the right with RRS and a mini perk and to clear the stone. And here is again in 2018, he's back again with the stone. And here again, we did a PCNL and clear the stone. Here we did biochemistry, and we found 24 hours urinary metabolites, hypercalciuria, and hyperoxaluria. So in since 1985 to 2020, we have done 31,608 stone treatment. And we have included open surgery has become less. And one measure was the PCNL, and then the ureteroscopy for the lower ureter and the flexible ureteroscopy. And this is the we were using. Now, we defined the true recurrence is a recurrence of a new stone in a previously stone-free patient, confirmed by X-ray, initially by KOB, then the CT scan, and then ultrasound. And we found that we received 472 cases. That comes to about 1.49% of cases we treated, they have come back with a stone. The residual stones were not included, and the regrowth was defined as the enlargement of the residual fragments. Here, we found that the one recurrence was in 69% of the cases, 326, and more than one, maximum 7 recurrence, we found in 146, that is 30% of the cases. Now, how long they took the time to form a stone? We found that for 5 years, 58% recurred. In 1 year, 9.53, 1 to 3 years, 31%, 4 to 5, 17%. And after 10 years, nearly 12%, they recurred. So how far is the involvement factor? Already Brian and Pradeep has talked about it, and this is the belt which we have, and right from the cutting across the country, we have a large stone burden in these cases. Now, of course, everybody has talked about the dehydration and supersaturation. This is a place, Kodinar, which is not far from here on the western coast. And here, the 100% stone in this village, every person clears. And because of the salination, because the sea is very near, salination, they use the water from the well, and then there's a high climate, high mineral content in drinking water, sunlight exposure generate vitamin D metabolites, sweat, high physical activity, poor water intake, lower urinary volume, high oxalate and calcium diet, high urinary calcium excretion, and high pH. And water quality, inverse correlation between drinking water hardness and the urolithiasis. The soft water leads to high stone incidence and hard water leads to low incidence. That's what we found. The high stone incidence in low magnesium to calcium ratio in the tap water and lower in the high ratio. Here again, everybody talked about the temperature. We found that every degree Fahrenheit you increase above 80, 150 ml, you lose in 24 hours by way of perspiration. And remember, in summer, we have a temperature of 100 to 115 degree Fahrenheit. So how much, if you are in a sun for a 1 hour or 1.5 hours, probably you will lose about a liter of fluid. Now, of course, people have talked about the marathon runner and the hot metal workers. Brian has mentioned the beach lifeguards and hot areas, which we see in the near the desert. They have the more prone. Now, of course, this was a standard treatment. The sufficient intake of fluid was one of the most important preventive measures for the stone recurrence, and high intake of water with a salt and a urine dilution results in a marked reduction in the saturation of the lithogenic salt. And this has been standard practice, which we've been doing it. And usually recommended is 3 liters per day, and dilution is the most important. Most common type of beverages we used to do, which was protective, is lemon juice with salt and buttermilk. While the promoters were, of course, we are tea drinker, and beer and wine, of course, Gujarat is a prohibited area. So how much is the stone factor responsible for stone recurrence? Now, we found that every size of the stone is associated with recurrence, but maximum is up to 3 centimeter, you have a high recurrence of the stone. But we had a Stegon calculus and a multiple calculus. They have a recurrence, but they're not so much as a stone in the, which is a smaller stone, probably they recur faster. Again, the location, we found the pelvic stone or a lower callosal stone, they do recur, or a multiple stone, they recur much more in this group of recurrent stone patient. But still, in all the calluses, there is some percentage of recurrences there. Then stone analysis, we found that the 90% the stone recur was the calcium, and 2.5% was the uric acid, and struvite was only 7.5% in our series. And then when we analyze a metabolic evaluation, 261 out of 472, hyperoxaluria was 74%, hypercalciuria was 47%, hypocitraturia was 41%, hypomagnesuria was 7.3%, and hyperuricasuria was 4.9%, much less. Management. Here we manage the stone initially with the open surgery, but not that is gone. ESWL, PCNL, urotoscopy, and medically. But now we stopped using open surgery and ESWL. Instead of ESWL, we use a microperk for the small stone, which is in the calluses, which is much easier to tackle than a ESWL. Highest recurrence rate reported after a endological procedure in this series, open surgery, spontaneous passage, or ESWL in a conservative treatment. But we found that ESWL had a highest recurrence, open surgery had the highest recurrence, then comes the endourological procedure, and the conservative was the list on our study. Which kidney factors were responsible. Of course, the congenital anomalies like malrotated kidney, 6 patients had a malrotated kidney, 4 patients had a duplex kidney, 9 patients had a horseshoe kidney, and 1 patient had a pelvic kidney who had a recurrent stone. Now, hydronephrosis, is this associated with a recurrent stone formation? Well, if you see, hydronephrosis was present in 66% of cases, but mild in 45%, and no hydronephrosis in 34% who had still recurred in stone formation. Infection, now 83% of the stone had no infection at all. Recurrent stone had no infection at all. Only 16% was responsible for who had an infection, and the majority of them were E. coli or Klebsiella, who were responsible for associated with a stone formation. What about renal function? And only we found that the renal 85% had a normal renal function who had a recurrent stone. Only the 14% had a CKD more than 1.5 in 68%, which is associated with recurrent of the stone. What are the patient factors? As has already been told, from the 21 to 60%, patient had much more stone, but maximum stone which we found, recurrent stone, was between the 41 and 50. Even though they may have started forming the stone and a treatment earlier, but they had a recurrence of the stone between this age. What about the sex distribution? The male was predominant compared to the female. That was seen everywhere. And here we found that as the recurrence might be more frequent in males than in female due to the predominant activating factor in the males versus the inhibiting factors in female for a stone formation. It was reported 2007, it was a 50% in each of the sexes. Then as the year progresses, we find that the males are more predominant compared to the female. At the moment, here 1 to 0.5 ratio between the male and the female. And present term, of course, the pain, hematuria, Lutz fever, etc. Eating habits. And we are 14% had vegetarian who developed a recurrent stone, while 85% were non-vegetarian who recurred the stone. And the family history, the 12.5% had a family history, and then all of them, 14 had a father had a stone, mother had a stone, brother had a stone, sister had a stone, and more than one had patient had a stone in the family who had multiple members had a stone. The stone metabolism here that is the recurrent stone. Now in a normal stone, we did the analysis and we got about 1900 data collected. The male were, of course, much more, 79% compared to the female, and age 50, nearly from 31 to 60%. 60 age, the maximum number of stone formation was there. And here is an analysis of the stone, structural analysis. Calcium oxalate monohydrate was the maximum, followed by dihydrate, uric acid, carbonate, apatite, and as all types of stone in a lesser amount was present. But calcium oxalate stone was the maximum in our series. Now, looking at the urine analysis, urinary calcium was above normal in 46% of the cases. Urinary oxalate above normal in 56% of the cases, and citrate was below normal in 16% of the cases. Normal in 81% of cases. The citrate was not much low. Citraturia was not the much common factor. Urinary magnesium was below normal in 45% of the cases. This was important. Urinary phosphate was mostly in the normal range. Uric acid, again, was in normal range. We didn't find it very high because of the all vegetarian population. When urinary creatinine was, again, in the normal range. Now, if you look at the stone analysis, calcium oxalate monohydrate had a multiple ranges. He had a hypercalciuria, hyperoxaluria, and a hypomagnesuria. And the 44% had a urinary phosphate, which was lower level. And calcium oxalate dihydrate stone, again, it was urinary calcium was high in 44%, oxalate was high in 73%, and magnesium was 39%. It was low, and in uric acid we didn't find anything significant in the range. So high recurrence calls for a vigorous effort to effect the complete removal of all stone. That which we have been doing it in last 3 to 4 years, we've been able to achieve 96% to 100% stone clearance, along with the thorough evaluation of the associated factor. Low urinary volume is an important risk factor in the stone. We realize that, and we always insist that they should drink more. At least they should have 1.5 to 2 liter output. Adequate intake, about 3 liter to 3.5 liter fluid in the summer, maybe 2 liters in the winter. Most important therapeutic measure, irrespective of the stone composition. So although the how to shape the future still in your hand, and that's why we have starting a stone prevention clinic, Glenn Preminger Stone Prevention Clinic, to make sure they don't form the stone again. Because it is very sad to see that once you're cleared completely, they come back with a stone formation. Thank you very much.
That's very nice, Mahesh. That's a tremendous experience, and we're indebted to you to have so much data and to be able to use that to, again, help to identify how we can better prevent stones.
Well, Glenn, it was you who stimulated us to do this about 20 years ago, and now we are doing the collection. We got a 3,600 analysis. We were hoping to present now, but it was impossible. But remember, we are going to send all this data to you to see what you make of it, and then help us out. And then
I'm going to save it. Then I'm going to send it to Dr. Goldfarb.
Yes. So that's why, David, I was very keen to have a Rock Society meeting here, because not me, but everybody in India is the same problem. And then we should be now we have mastered the technique, but we have to master the prevention. That is most important.
Yeah.
And now I invite David to give your talk on the metabolic evaluation of the recurrent stone former. You have seen our problem, so you can.
Fantastic, Mahesh. Thank you so much for having me. It's really a great honor to be associated with you, to have traveled to Nadiad in 2017, and to be with this group today. Glenn, congratulations on having this prevention clinic named after you. I think that's a perfectly deserved honor. As one of the children of Charlie Pack, absolutely something that a feature that many urologists have emulated, have taken from you as really one of the first people interested in metabolic stone evaluation and treatment, and so you've served a very important role in making that part of nephrology something that urologists are interested in. So definitely a deserved clinic. We're going to open a Glenn Preminger clinic here in New York as well. It's going to become a chain and a franchise, and really deserved Glenn. So it's really a privilege for me to be here today. All of the talks have really served as an important introduction to the topic that I'm going to discuss as well today. So we can bring up my slides.
Are you going to, should we put it up?
Yes, please. Yeah.
Yeah. All right. Okay. Just a minute.
Okay.
Just a minute. So, David, I was talking to our nephrologist. They are not interested so much in stone. I said you should attend this meeting and then see how David has been involved and has made an impact on the prevention of the stone for me.
Right.
See, David is the uronephrologist.
Right. That's it. Thank you. It's a niche that I'm trying to expand and attract more people to. So I'm going to talk about management, the medical management, and just go back a slide, please. The AUA guidelines. Here we are. Peggy Pearl is the first author. Several nephrologists here: Gary Curhan and Cindy Denucocia. Glenn as well. So we appreciated the AUA including some nephrologists to discuss the guidelines. Next slide. And the guidelines include clinicians should perform additional metabolic testing. And that metabolic testing is doing 24-hour urine collections. And the grade of evidence is considered moderate. Glenn presented discussion about doing 24-hour urine collections and comparing that with stone composition. Mahesh also had all of that new data from Gujarat on doing 24-hour urine collections. But I'll have to really point out that this has been a somewhat controversial topic. Next slide. Of course, the 24-hour urine collection, what are the analytes that are being specified, are the things that Glenn and Mahesh in particular have spoken about this morning, the usual things related to stone formation. And in discussing this as a controversial topic, is this an important part of stone prevention? I'll point out at the bottom here that the urine oxalate is the best reason to find to do a 24-hour urine collection in order to find those patients who have primary hyperoxaluria. That is a rare disease. It's rare in India. It's rare in the United States, but it is a disease with significant implications, particularly the risk of kidney failure, the need for kidney and or liver transplantation. And so we're not really going to suspect that rare genetic disease unless we do a 24-hour urine collection and demonstrate a high urinary oxalate, because otherwise we just think of those patients as having calcium oxalate stones like everybody else, although they tend to have more stones, younger onset, of course, and more chronic kidney disease associated with it. But that's a good reason to do a 24-hour urine collection. Next slide. So the truth, though, is that in the United States, 24-hour urine collections are done infrequently. In a group of patients that were reviewed by John Hollingsworth and Stuart Wolf, they found, and they defined these patients as being at high risk. The patients that Mahesh was talking about as having a high rate of recurrence, these were patients with a variety of comorbidities that led them to conclude that these were high-risk stone formers. You basically can see that on the y-axis, the number of patients that had a 24-hour urine collection done was about 7%. And it looks like it increased to 2005 and 2006. Not really. It went from 7% to 8%. So the graph is a little bit deceptive. Most patients with recurrent kidney stones or at risk for kidney stones did not have a 24-hour urine collection in the United States. You can see that the odds ratio for getting a 24-hour urine collection were greater if you saw a urologist than if you saw a nephrologist. That's slightly embarrassing to me, but it's to the credit of urologists that they care about this, and Glenn is certainly a pioneer in thinking about this topic. Why can we conclude that a 24-hour urine collection was not done in most people in the United States? It's evidence that the United States is, as we've seen this year, a backwards country, perhaps. That's one possibility. Another possibility is that it's not considered that important for evaluating and managing patients with kidney stones. Next slide. And I'll just point out that one of the issues has been that in this review written by the American College of Physicians, and the authors of this paper, as I like to point out, none of them has ever written a paper about kidney stones. None of them has ever seen a patient with kidney stones. I don't know if any of them have ever had a kidney stone. I'm not sure. But they definitely reviewed the literature and found that there were really insufficient data to conclude that looking at stone composition, blood chemistry, and urine chemistry before initiating therapy reduces stone recurrence. And this is a real problem. The data demonstrating that we need to do these things in order to prevent kidney stones is kind of lacking. There's only one good quality study as far as they're concerned, and that study is the Borghi study of diet for kidney stones. Next slide. So based on all of that data, I co-authored this paper with Ryan C., who at that time was another one of those accomplished Stoller fellows. We wrote this paper, and the urologists asked me to participate because they were writing a relatively negative review about the role of 24-hour urine collection. Be the thumbs up while they were 3 thumbs down. And so this paper is something where their opinion that was relatively negative is a paper where I had an opportunity to put a more positive spin on the role of the 24-hour urine collection. You can see that since 2017, when we wrote this paper, it actually influenced me. And I wound up understanding why there was a negative view of 24-hour urine collections and why perhaps most patients in the United States were not getting urine collections done. Next slide. There is evidence, though, that, and this is really relevant to Glenn's talk on stone composition, this paper from John Aspelin and Fred Coe showed that supersaturation, that's a value that's not measured, it's a value that's calculated, that supersaturation did correlate with the kind of kidney stone. So when you get a 24-hour urine collection, it may be that the most important value is not the amount of calcium or the amount of oxalate or the amount of citrate, but the supersaturation, because there's a good correlation here. You can see that on the x-axis is the supersaturation of uric acid, and that was highest on the far right there for patients with uric acid stones. The y-axis is brushite, and you can see that that was highest for patients who had calcium phosphate stones. And the supersaturation for calcium oxalate is the z-axis, and that was elevated for patients with calcium stones as compared to mixed or uric acid stones. So there certainly is a value in getting the supersaturation as correlating with calcium with stone composition, calcium or uric acid, or the like, and Glenn discussed that data. Next slide. But as a result of my visit to Nadiad, and at that time, Mahesh, you were not getting 24-hour urine collections, and right up the street from me in New York City is the City Hospital, where most patients don't have insurance in our backwards healthcare system. That's Bellevue Hospital. Many of you have heard of it as New York's biggest, most famous, and large public city hospital. As a result of writing that paper with Marshall Stoller and Ryan C., visit to India, where 24-hour urine collections were not being done at that time, I was asked to write a paper about empiric therapy. And this paper in urolithiasis is something that I've since really been interested in. I'll show you that. And we wrote, we acknowledge that no study has shown that managing patients based on a 24-hour urine collection is superior to prescribing empiric therapy without 24-hour urine data. Careful implementation of an empiric prescription based on stone composition would have an important effect to reduce stone recurrence in the world's many stone formers. And here I was really thinking not just about my visit to India, my visit to New York City, Bellevue Hospital, and lots of places where 24-hour urine collections are not being done. Next slide. So thinking about what those empiric therapies are, and here I want to say that I talk to my patients about these things as though I were talking to them about the next medication that I was going to give them. Lifestyle and weight loss is clearly important, as our growing kidney stone prevalence is correlated with growing weight. Metabolic syndrome, diabetes is very important. Mahesh talked about fluid intake. We certainly want to encourage people to increase their fluid intake to a total of 3 liters per day. And we don't care what that is. Water, of course, most of it. Nothing wrong with coffee, juice, beer, wine, whatever it is that you like to drink. I know in India, it's Macallan's 16-year scotch. All of the fluids are appropriate to drink a total 3 liters per day. But Brian showed you data about occupational kidney stones. There certainly are people who can't do this. Either they don't want to be thirsty, or they cannot they can't drink more when their thirst has been suppressed, or they have occupational issues that lead them to not have access to bathrooms or not have access to fluids. So that's a significant issue. The diet is something that we can modify, and this is certainly something that is worthwhile. As Fred Coe has pointed out, it's worthwhile for good health. It's good for cardiovascular health. It's good for vascular health. Less sodium, less animal protein, and more dairy, as the study showed. So looking at a diet that is like the Borghi diet, which is high in dairy, or the DASH diet, which is just a little bit less animal protein and more fruits and vegetables, these are diets that have been associated with kidney stone prevention. And then it's possible to prescribe medications not based on a 24-hour urine collection, but simply based on the fact that you have a kidney stone. And both Glenn and Mahesh were open to this possibility. You can certainly give people more citrate, potassium bicarbonate, and it's even possible, and I'll show you why, to prescribe a thiazide in a calcium stone former, to prescribe chlorothalidone or indapamide in order to reduce urine calcium and prevents kidney stones. It's not absolutely necessary to have a high urine calcium. If the urine calcium is so-called normal, make it lower, make it better. And of course, when I give patients thiazides, I'm telling them I am lowering your blood pressure, therefore I am extending your life expectancy, and I am preventing kidney stones as well. Alendronate, a bisphosphonate, there's a high rate of osteoporosis in patients with higher urine calcium and calcium kidney stones. And alendronate has now been associated. Now, there are very good papers from Gary Curhan's group demonstrating that bisphosphonates are associated with better bone density and prevention of kidney stones as well. And that's something we need to think about when we're serving our patients as internists as well, thinking about their bone density. Next slide. So water is intuitive, inexpensive, and accessible, and it's over the counter, as we like to point out. So these are the things that make this a very important medication. We have to talk to our patients about the fact that this is a medication with a dose. There's a dose and a compliance that's required, and we really need to spend a little bit of time talking about what a high urine volume is. But I understand that there are patients who can't get there for a variety of reasons. Next slide. Reducing sodium intake prevents stones, extends life expectancy, and improves bone density. Increasing dairy intake helps prevent stones, improves bone density. And reducing animal protein intake prevents stones, prevents COVID, global warming as well. Next slide. Thiazides reduce the urine calcium and prevent stones, and they worked in patients who had normal urine calcium. That calcium is now going into bone. As I explained to my patients, they're going to have a better bone density as well. And citrate, however you give citrate, as potassium citrate or as fruits and vegetables, will prevent calcium stones, of whether oxalate or phosphate stones, lower the urine calcium, and increase bone mineral density. Brian Eisner's got a nice paper showing that citrate made calcium go down, urine calcium reduced as well. And there are nice studies from Switzerland demonstrating that potassium citrate is associated, because it's titrating acid, is associated with increased bone density. Next slide. So the result of all of this is that Ryan C., who I wrote that paper on 24-hour urine collections with a couple of years ago, Ryan is putting in this grant, selective versus empiric therapy on kidney stone risk. And we're working on it this week. To put this in as a randomized control trial. Next slide. And the way this would go, there's two groups of patients, low-risk stone formers and high-risk stone formers that are in this study. The low-risk stone formers are the patients who have had a single stone. Smaller stones, or the high-risk stone formers are the patients with recurrent stones. Next slide. So the study design here is that the low-risk stone formers will be randomized to an empiric diet. It's something like the Borghi and DASH diets, more fruits and vegetables, less animal protein, less oxalate, less sodium. versus a selective diet, a diet that's simply based on a 24-hour urine collection. Here's what's wrong with your urine. Here's what we're going to do about your urine collection. We're going to give you a diet specifically based on the abnormalities that you have in your collection. Next slide. Next slide, please. And the next, there's a slide. I don't know where that's. There's another slide. Here we are. Thank you. And so, yeah, aim 1, aim 2. We take the high-risk stone formers, and here the empiric versus selective therapy will include medications designed to treat the patient's 24-hour urine collection. So that aim 2 design will include pharmacologic therapy, not just empiric therapy. Next slide. So my conclusions were that preventive therapy based on the 24-hour urine collection is attractive. It appears scientific. It might be better than empiric therapy, but it really hasn't been proven. There's really a lack of data on this subject. Empiric therapy has the potential to affect a larger proportion of the world's stone formers in places where 24-hour urine collections are not available. That's most of India. It's parts of the backwards healthcare program in the United States and New York City in particular. Next slide. That's my last slide. I really appreciate the opportunity to speak with you today. I want to congratulate Glenn again and Mahesh for putting this program together and including me. Thank you.
Thank you, David. I just wanted to ask you one thing regarding the sodium intake. And you know that we are very hot. In most of the time in the summer, mostly in summer, up to say from March till September, if you go out, you lose water. Your urine volume is less because you sweat more, not because you drink less. And when you sweat, you lose water and you lose sodium.
Correct.
So if you only replace the sodium, you have a water intoxication and people may feel giddy. So you may need to replace the sodium. And that's why we have a food habit which has got a little bit more sodium, like papadum or pickle, and then we have to take that. Otherwise, we'll have a low sodium. So, I mean, because of that, we have to adjust according to environment regarding the sodium.
I agree, Mahesh. It's a really interesting point because if you think about it, if you were sodium depleted, you would have less urine calcium in the urine. And yet the fact that people make stones in the summertime, despite being a little bit sodium depleted, is interesting. So Fred Coe has some data from the University of Chicago. This is not Litholink, it's University of Chicago data. And it shows that in the summertime, women are better at maintaining a higher urine volume than men. And it suggests that there's a difference. One of the differences between men and women is that women somehow are better at repleting their sodium and water losses than men are. And that might happen to, that could be a hypothalamic function. It could be CNS that leads people to have different responses of thirst. Women somehow drink more fluids in the summertime and have a higher urine volume than men. There's very little data like that. But our discussions about the effects of temperature and climate, which Brian talked about and Pradeep talked about, is really interesting because one of the differences is, as Brian showed, we've had data that demonstrate that women have a stronger environmental component to stones than men. And it could be that they're better at responding to the environment and keeping up with their fluids than men are. So I agree with you. We've certainly explained to people that drinking something like Gatorade has some sodium in it and will help replete that. It has some citrate content. My conflict of interest includes the fact that Brian and I and Marshall Stoller have contributed to making a drink which is high in citrate. It's got a little bit of sodium in it as well. So I agree that a complete sodium restriction in the summertime is not necessarily appropriate.
Well, thank you so much. It has been very nice. And now I think Dr. Sabnis is going to present the problem which we have. and he has selected a couple of cases for you to opine. Subnis would like to start, and he will also ask the questions which has come.
Yes. So thank you very much. I think it was a wonderful experience talking to and listening to all of you. One question which has been asked by many people, and I want Dr. David to comment on that, is that a lot of people eventually take a lot of calcium supplementation for various reasons, whether they are old age, they are advised by the orthopedic people or whatever. So this question has come in the chat box by many people, that what is your advice about that? If they have stones, do they continue to eat, take that calcium supplementation? Do they stop? What is your advice on that?
So there's lots of supplements, right? And there's amazing that people want to take vitamins. And I have no idea why people spend that money. For instance, yesterday I saw someone who was taking a lot of vitamin C. He was taking vitamin C because the possibility that somehow that prevents COVID.
Yes.
Vitamin C.
COVID.
Yeah. So we expect, like, I want to write the first case report of COVID-induced kidney stones. And the way that happens is that either you're oliguric because you're wearing a mask all the time, and you can't drink anything, so you go around with a low urine volume. I think that's what's been happening to me for the last 6 months. Or you're taking crazy things like vitamin C. So as I explained to my patient yesterday, the only thing that vitamin C prevents is scurvy. And the only reason I ever recommend take a vitamin C supplement is because you're going to take a trans-Pacific boat ride, and you can't bring lemons and limes with you. So every study has demonstrated that vitamin C from 80 milligrams a day to higher doses is associated with more kidney stones in a pretty linear manner. Ascorbate metabolized to oxalate. Everyone really believes that that's important. So that's an example of a bad idea. Calcium supplements have been really disappointing for postmenopausal osteoporosis. And in the Women's Health Initiative, calcium supplements were associated with an increase in stone incidence from 1% to 2%. So a doubling. It's still a small number, but it didn't do very much for bone density. When people want to take calcium supplements for bone density, I recommend that they take calcium citrate, because their citrate will go up a little bit, and that they take that calcium citrate with meals in order to have the calcium serve as an oxalate binder. Other vitamins, I think, are probably not important, and so the two that I worry about are calcium and vitamin C.
What is your opinion? That's a nice answer. And what is your opinion about the dietary calcium intake as against to the calcium supplementation in the tablet form? Do they act in the similar way, or dietary calcium actually there is no problem in taking even in a excessive amount? So what is your opinion about that?
That's a very important question. The calcium, all of the calcium as dairy, as part of the diet, all of those studies have been consistent in showing that more calcium intake is associated with fewer kidney stones. And presumably you're taking the calcium there with food so that some of the calcium is binding oxalate in the intestinal lumen. And Curhan and Taylor's data showed that not only was that calcium from dairy, it was also from non-dairy products. Like it's used to bake bread and make a variety of other foods. Usually I don't recommend calcium from vegetables because most of the high calcium vegetables are also high in oxalate. That's not a coincidence. The calcium is there to prevent the plant from dying of its oxalate poisoning. So that is, I usually think that any dairy and other non-dairy sources of calcium are better than calcium pills, because the calcium pills are often coming between meals where it's simply adding to blood and then urine calcium and not serving as an oxalate binder.
Good. Thank you for that absolute clarity on the issue. And we'll go to the case discussion. Basically, these cases have come, I have selected just to discuss out as to what exactly the problem which we face And this is a problem. It is not only the peculiar to our institute, but it is across the country. And therefore, I'm sure there are a lot of people who have been watching will be benefited by the expert advice from you. Well, this story actually starts from 1991. That time, this was a 34 years old male. He had the right flank pain off and on for 1 year. History of lithuria, just a lithuria 3 years back. That time he had left side pain, probably passed the stones, and eventually the pain disappeared and nothing was done after that. And we don't have the detail, but now he has come with the right side flank pain. And this is the X-ray. This was 1991. We were doing routine conventional IVP at that time. And you can see here that he has a significant stone in the pelvis and the small lower calyx. Left side is perfectly all right. So as anybody would do, the PCNL was done. The stones were completely cleared. Post-op X-ray, ultrasonography, everything was fine. He went home. The question is that the first-time stone former, requiring intervention, does he merit complete metabolic workup? I think you gave lots of insight as to whether to evaluate and whether to give empirical therapy or not. But I want to ask Dr. Glenn Preminger that in your practice, if this is a patient who has come for the first time stone intervention, will he be subjected to the extensive metabolic workup? So what is your advice on that?
Well, I think that's really a very important question, because some people will argue if you take a young individual and put them on lifelong medical therapy, are you really doing justice for this particular patient? Yes. And so, as David has mentioned, and Brian and Roger as well, I think we also have to look at what the risk factors are. What the risk factors are for further stone formation. Now, this guy had at least 2 stones, yes, and a very large stone, and he needed percutaneous stone removal. So I think that this would be an individual who, while we can't perfectly predict his risk, he doesn't have a family history, he doesn't have other associated medical problems, I would offer that he probably wouldn't want to have another percutaneous stone removal. And so I would offer him selective medical therapy. I would say, yes, we would definitely want to do an evaluation. Now, as David suggested, unfortunately, there's a lot of people who refuse, or we recommend this. I just saw a lady the other day who we had done a percutaneous stone removal on. And then she never came. She came back for one postoperative visit. We said we want to do 24-hour urines, and then we lost her for 10 years, and now she has both kidneys full of stones, just like what Mahesh showed. Right. So I think it is concerning that some of these patients do not want to undergo metabolic evaluation.
Right. Now, I want to ask this question further to Brian, that when we consider the medical evaluation, do you differentiate a simplistic evaluation or the concise evaluation in the beginning? And if you find something abnormal, then you go ahead with the extensive metabolic evaluation. Or if you have extensive stone, multiple bilateral stones, then you go straight away for the extensive or a concise. So what is your idea about that?
Yeah, I think these are very good questions. I think what I would start with by saying that our guidelines, and we have several esteemed members of the guidelines panel here, recommend that any recurrent stone former be offered an evaluation, right? But of course, those can mean many different things, right? You could have someone who passed 2 1-millimeter stones versus someone who's had multiple bilateral PCNLs, and those mean 2 very different things. The approach that I tend to take in my clinic is that, for this patient, and I think what Glenn said resonates, I say to them, look, I think that if I can figure out what medicine may be the most useful for you, I probably can get you better prevention than dietary recommendations alone and lifestyle recommendations alone, but it's up to you. If you don't want to take the medication, then I'm not sure what I'm going to gain from doing a 24-hour urine for you. But if you want to know whether your citrate's elevated or your calcium's elevated, then perhaps, to consider going on thiazide or potassium citrate, then I think it may be useful to do a 24-hour urine. I will say that in this very young patient, let's assume a calcium stone composition, at the very, very least, even if they refused a metabolic evaluation, I would want to get a serum calcium, because a young patient with stones like that, I think you have to be worried about missing a diagnosis of primary hyperparathyroidism.
Yes.
In the States, it's only about 5% of all calcium stones. But I think for a young person who made a staghorn like that and 3 stones on the other side, a simple serum calcium, which they've often come to me already with, will at least help me have some confidence that they don't have primary hyperparathyroidism. But here, I tend to offer the patients things that are compliant with the guidelines, but also let them know that if they have no interest in taking medication, that I'm not really sure what huge benefit a 24-hour urine is going to give us.
Yes, I think that's a very, very logical advice. Yes, please go ahead.
I just want to make a comment here.
Yeah, please go ahead.
For our viewers, all stone patients, kind of like Ryan has talked about, we have our guidelines. All of them should receive at least a screening evaluation. And what I mean by that is there are things that we can do that are real simple that may unmask underlying problems. A complete dietary and medical history. For example, in that, you might uncover that they're taking vitamin C or Topamax or Topiramate or something, or maybe they're on a fad diet, or maybe there's something in their history that's going to reveal it. Some basic serum chemistries, a Chem 7 with a calcium and a uric acid are always helpful. The urinalysis itself, obviously looking for, under the microscope, looking for crystals that might give it away that it's cystinuria or, a urine culture, because you're looking for urea splitting organisms. Obviously, if you can perform a stone analysis like Glenn's talked about, that might be very revealing. Perhaps you're making a uric acid stone.
Yes.
And then some baseline imaging. So I think all those patients should receive, at least at a bare minimum, a screening evaluation.
Right.
And when and if that screening evaluation reveals some risk factors that you've all talked about, at that point, you might want to consider a more comprehensive, i.e. a 24-hour urine, if you believe in it.
Right. Yes.
So I just want to make that comment.
Yeah, I think that's a perfectly correct advice, because unless and until you do this screening evaluation, you won't know how far you want to go ahead with the extensive evaluation. Well, in
you might find something.
Yeah, we may find something. So in this case, serum calcium, phosphorus, uric acid, protein, electrolytes, they were normal. 24 hours urinary calcium, phosphorus, uric acid, oxalate, magnesium citrate, all were normal. Well, he was a vegetarian diet. Looking into the other history, he was otherwise the office work, not so much of exposure to the heat outside. He's a vegetarian diet, purely vegetarian, not taking any meats anytime. And therefore, the common advice, so-called empirical advice, was given to him that to drink the plenty of fluids. Really, there was nothing much to change in the lifestyle. Now, David, this is what we find often, that you do evaluation of 24 hours thing. And even though these patients who have bilateral stones, even though they have recurrent stone, they have needed intervention, the evaluation often comes to normal, and eventually it comes to a plenty of fluids is the only advice. So what do you say about that?
Yeah, very important question. And we did deal with this in the AUA guidelines. I think the answer is, and patients do come to me, they say, my 24-hour urine collection was normal. And people told me that there was nothing else to do. My response is, if your urine collection is normal, I'm going to make it more normal. It's not normal for you if you are making kidney stones. Therefore, and part of what I said in my talk was, I can give you potassium citrate even if your citrate is normal, or advise you to take more citrate, bicarbonate, even sodium bicarbonate if necessary. If your urine calcium is normal, I'm going to make it more normal. I'm going to lower it, and I'm going to give you a thiazide if you tell me that your kidney stones are such that you are not going to tolerate having more kidney stones and then another percutaneous nephrostomy. So I think the answer is there's no such thing as a normal urine chemistry in a person with kidney stones. It has to be more normal or made at least better.
Right. Okay.
I agree. I follow this for 1 second. I'm sorry. I do want to make a point. I think the patients come in very frustrated. My urine's normal, as David said. But one thing I tell them, which gives them a peace of mind that we have to remember, is that there are thousands of proteins in the urine that go unmeasured, right? And there are many promoters and inhibitors of stone formation in the urine, Tam-Horsfall protein, osteopontin, that we actually know may promote or inhibit stone disease that also are unmeasured, right? So the 24-hour urine may be the best thing that we have, but there are many, many things that we actually already know contribute to increase or decrease risk of stone formation in the urine, but we don't have standard assays for them. And so I sort of do something similar to David in terms of offering them empiric therapy. But I to calm their nerves and their frustration about it, I do say, remember, these are not the constituents that come out on your 24-hour urine are not the only urinary risk factors for stone formation. They're the ones that are most easily measured and manipulatable, and we know they contribute to supersaturation, but there are plenty of other things in there that go unmeasured that could be contributing to your risk. And that's why the person with a urine calcium of 150 and a citrate of 600, that's at least part of the reason why some of those patients are making staghorns. But again, I still believe in manipulating what we can, as David does.
Yeah, I think that's a very, very important point which you have advised. And this is exactly what happens is that there are some patients who keep on coming again and again. They have stones. We do extensive evaluation. Everything is normal. They are frustrated. We have no answer. And I think what you have said is absolutely true, that this is how we need to approach. Well, going forward with this case, we came back 6 years later in 97 now, again with the severe right flank pain. And he had off and on pain for 6 months. And this was a stone. Now he has got bilateral stones. The right side, he had actually the stone in the pelvis. This is the IVP. The kidney cortex was good. This was the IVP done in the pain. Left side was normal with multiple stones. So it was a good stone, good cortex. Urine was sterile. And we did again the right side PCNL, complete clearance was obtained. We wanted to treat the left side, but he was not so keen because he actually had no pain on the left side. So he just went away, not willing for the surgery at the same time. But 4 months later, he came back that the stones actually have come down now. These stones which were in the kidney have come down into the ureter. And at that time, we had no RIRS. We had to do the push the stones back into the kidney and do PCNL and complete clearance. So this was again the story in 97, where he have from 91 to 97. Came back again 3 years, he was perfectly all right. Came back in year 2000 with again the right side flank pain. And now you see this stone again. There was a kidney stone, there was a recurrence on the right side. And at that time, the pain was not much. He lost to follow-up. We advised him treatment. He lost to follow-up. That's the usual story. Recurrent stone, multiple stones, patients get fed up. They don't want to come back again and again. But eventually came after 2 years again with the stone increase in size, pain increase in severity. And now we find that there is a pelvic stone, there's a lower calyceal stand which is seen. And again, we did the right PCNL, complete clearance was obtained. This time the left side was perfectly all right. We again evaluated because by then he was really fed up. And he had 10 years almost that he's forming the stone again and again, hampering the quality of life. The stone analysis showed calcium, oxalate, dihydrate, and monohydrate, the combination of this stone. And we did the whole metabolic workup again, including serum, parathyroid hormone, calcium, phosphorus, 24 hours, everything was all right. He said that he's taking a lot of water, but in spite of that, he's forming the stones again. So now, Roger, what is your advice on this now? He is frustrated. We are also fed up seeing him again and again. He's coming back again and again. We are doing just PCNL here and there and then. So what is your advice in this case? How do you go about it?
So I think these stone formers in this particular case speak to the fact that to borrow a phrase, it really does take a village to have just the urologist or just the nephrologist involved in the patient's care is probably inadequate. For example, in our clinic, we've hired a nutritionist to be involved. And I'll be honest with you, most patients are probably a lot more effectively treated by the nutritionist than listening to me. I might spend, 30 seconds, a minute at the most to change probably the most difficult thing we've asked them to change, which is their behavior, right?
Right.
Two things are almost impossible to change in anyone. Number one, their politics. Number two, their behavior. And we're expecting in 30 seconds that we're going to actually change their behavior. Like, we're fooling ourselves into thinking that. And so without enlisting a more comprehensive approach, bringing in nutritionists, bringing other people to help these people, ensuring follow-up, these patients are doomed. We're setting them up for failure. So I think we need to kind of it's 2020, come to the realization that we need to do a lot more for these patients other than spend 1 minute, 2 minutes at the most as a doctor and expect, oh yeah, they're going to suddenly increase and change their behavior completely. So I think that would be my point. And like I said, we've incorporated nutritionists and there's several other strategies we've done with the patients.
Right. I think that's very, very important that we have to really spend the time with the patient. And then I think it is very well known that there is a stone clinic effect comes in, and that certainly helps in prevention of the recurrence of a stone. And that exactly is the reason why we are starting the stone prevention clinic on Glen Preminger. Yes, please go ahead.
And Ravi, and it's not just us spending more time, because the reality is a lot of patients, we as physicians don't know how to speak to patients oftentimes. We tend to guilt them into things. We'll say, like, you're losing weight, aren't you? And the patients are afraid of us. They're like, oh yeah, I'm working on that. Yeah, I'm drinking all the time. We don't know really how to effectively help their behavior. Whereas when I talked to my nutritionist, she said, I would never use that phrase. Let me tell you how you talk to patients. We as physicians need to enlist and leverage other specialties who know how to really help patients. We know how to be great surgeons, but our forte isn't behavioral modification. So I think we need to recognize that and use other people.
But to go a little bit beyond behavior, Roger, at this point, if this patient's coming back to me, I'm saying whether it was that we didn't start therapy back 2 years ago, whether they didn't want it, I'm not saying to them, this is your third PCNL, you're not on any medications. At this point, and again, this is what David taught me, but this is how I do it. I'd say, you're young and healthy. I don't see a lot of risk. And to be honest, with that many perks, this patient hasn't just shown they can make a stone. They've shown they can make a big stone. And I think that's a different phenotype, right? Because we both know there are people who pass a few small stones every year. That's very different than needing a PCNL every 2 years. So this patient, if they said to me, I want something more than just my diet, I agree with everything you're saying about nutrition and getting other people involved, but I'll be very frank. I would consider saying, in addition to all that, I'd give you something like 50 to 100 milligrams of chlorthalidone and 40 milliequivalents a day of potassium citrate. And I think for a young patient like this, it's time to get aggressive if they want, because 3 perks in the 6-year period or whatever the number is, that's a lot. I mean, that's a lot of trauma to the kidney.
Yes.
I agree with Brian and David that there have been a number of studies that even if the 24-hour urine looks good, you can make it look better. And with empiric therapy, with lowering his calcium even more and raising his citrate even more, I think that you have an excellent chance of getting his stone disease under control. Now, again, part of the problem with this individual is he's doesn't sound like the most compliant or individual. And so, the patient needs to bring something to the table. But I think a lot of times when we're in clinic, I'll have the resident, after he sees the patient, come and tell me about him and say, well, this guy's 24-hour urine is normal.
Right.
And my comment is, well, he didn't drive 4 hours to come see us because for me to tell him that his urine is normal. He came to see us because he wants some type of treatment.
Right.
Or she. So I think we need to be aggressive, and I agree 100%. And the stone composition here as a calcium oxalate, monohydrate, and dihydrate lends itself well to empiric therapy with chlorthalidone or indapamide plus potassium citrate.
I think Brian has made a very important point that this patient certainly needs a very aggressive treatment. And what happens is that we advise them the potassium citrate, the thiazide, they start taking that treatment. They continue for 4 months, continue for 6 months, continue for 1 year. After that, they get some. Gastritis. The treatment becomes expensive, and eventually they lose interest. And the moment they lose interest, maybe 1 year, 2 years down the line, they come back with the stone. So this is the usual story. I want to ask you that when you give these patients a long-term high doses of citrate, how often they tolerate this citrate in the form of a gastritis and stomach upset and all these things. So what is your experience about that?
I can say something about that. So
please go ahead.
The usual number people cite is about 20% of patients with who don't tolerate potassium citrate, and I think that's reasonable. I think it's higher in older people. I think it's important to say that the citrate should be not be taken on an empty stomach. It should be taken after meals so that that effect is somewhat reduced. I think potassium citrate can be given as a liquid form and diluted as much as possible so that it's not a big shot of potassium in the intestinal lumen. Sometimes patients do better with potassium bicarbonate than potassium citrate, and partly that's because the potassium bicarbonate preparations are usually as an effervescent tablet, dissolves in a glass of water. Again, larger volume, dilute it more. And part of the idea of the drink that we invented was that it's a little sodium citrate, a little potassium citrate, and a little magnesium citrate, which I think has also been associated with fewer GI side effects. But ultimately, if you don't have access to those kinds of preparations, I think increasing oranges, lemons, grapefruit juice, all of those citrus things, melon, watermelon, cantaloupe, all of the watery vegetables are going to help you increase urinary citrate.
David, I just want to give you the idea. We did one actually study and with our own healthy individuals, and we supplemented the citrate juices and other things to see how the effect comes in the urinary citrate excretion. And what we found is the amount of juice which you have to actually take is so high that most of the healthy individuals just refuse to take that much amount of the juice so as to increase the citrate levels in the urine significantly. So what is your experience about that?
Yeah, I agree. I think that it's not so easy to change your diet from that point of view. If you don't have access to the potassium citrate pills or potassium bicarbonate, it's difficult sometimes to do it. And that's part of the idea about why we invented a low-cost, over-the-counter, non-prescription drink, because it's not easy to do it. Charlie Pack showed that orange juice was better than lemon juice, but all of these things, I totally agree with you. The volume is sometimes excessive, and the carbohydrate intake, the intake of glucose, is significant, and we don't want to give more calories to our overweight kidney stone patients.
Right.
Ravi, I just want to say one thing about another option that we published in the Gold Journal was the use of just baking soda, which is effectively sodium bicarb. And I'm not sure if that's something that's available locally in India, but what we did was we took 1 teaspoon of baking soda and then took an orange and a lime or a lemon, squeezed it in there, waited 15 minutes, because if you wait a little bit, it has less flatulence, less GI upset. And for my patients who can't tolerate potassium citrate and have GI problems, we published that they had no problems with this. And we actually were able to increase the urinary citrate. And equally important, we were able to increase your urinary pH, because the problem with a lot of these fruits is they won't increase the urinary pH oftentimes.
Yes.
So we found this to actually be a very effective way for patients who wouldn't tolerate either not modifying their diet or being able to take the other pharmacotherapy, because this is an over-counter, and we publish it in the Gold Journal if you want to look at the recipe.
Yes, I think that's a very, very important advice, that sodium bicarbonate is a very important thing. And I'm sure David also will agree that sodium bicarbonate, even though it is a sodium salt, is not that harmful like what we generally call it, the salt which is so harmful. Do you agree with that? That sodium bicarbonate generally does not cause that much of a problem as compared to the sodium chloride.
Sabnesh, one patient with a recurrent stone
Yes.
was treating, and he came and told me it is cheaper to do a PCNL than to take a medical treatment for all these years. They get fed up with the side effect, and they are not compliant.
Right. Right.
It's called natural selection.
Yeah. So anyway, just to go ahead with this patient, he came back again in 2006. There were small stones in both lower calyces, and the kidney, in spite of multiple surgeries, multiple interventions, kidney was working all right. Pelvic calcium system was perfectly okay. There was not much distortion, not much scarring. And we did that time, we had RIRS available. We did bilateral RIRS on the both sides. Stones were completely cleared. And that is what is the story. So it is almost the 16 years that he's been undergoing all these things. And sometimes we have no answer. Sometimes we give empirical therapy. And the situation in our country is different, as so rightly pointed out, that medical therapy sometimes becomes too expensive, and that is how they live with it. So this is what is a usual story. And probably apart from these probably are not the metabolically active stores, but these are all environmental factors, even though they are all office working, and is that, as it was projected in the study also, that the environment and the other things also come into the play, and that probably increases the stone formation. So that is a usual story about it. Any comment from anyone? Then we go ahead to the next case. Yeah, coming to this second case, this is the 12 years old male child. Now again, this story starts from 6 months of age. Is a recurrent stone former, bilateral renal stones. First time stone formation was at the age of 6 months of age. It was a stone at the right UEJ at that time, and the renal stone. And left side, there was a renal stone, and he had a bladder stone at that time. So bilateral PCNL cystolithotomy was done. At the age of 4 years of, again, he had bilateral PCNL. So by the age of 4 years, he has undergone multiple interventions. Again, in 2015, at the age of 8 years, again, he had bilateral stones, and we had to do bilateral MIP-XS, a small minimal invasive PCNL. So by the age of 8 years, he had already undergone multiple interventions for the stone. And then he came in 2015. No, this was in 2015, where the stone analysis was done, and it was 95% cystine stones and 0.5% protein and blood. So basically, it was a cystine stone, which he was forming again and again. He came back now after in 2019 with the flank pain for 4 days, vomiting, and urinary complaints. Investigations, creatinine was all right. His uric acid, calcium was normal. Urine was sterile. Urine was acidic. And in 2019, it showed the stones, and this was a stone. He had a single stone in the upper ureter, the single stone in the left lower calyx, and this was the CT IVP. It showed the stones, and this was a kidney which was functioning. Right side was obstructed kidney. So it was 808 HU stone, right side upper ureteric stone, 15 millimeter. Small calculi in the right middle and lower calyx, HU 816. Left side 13 millimeter lower calyx stone, which HU of 669. His uric acid was quite all right. His ureteroscopy was done, PCNL was done, stones were completely cleared, CT scan was post-op was normal. His uric acid is 7.4 and calcium is 9.9. So he has a cystine stone on analysis. His uric acid is 7.4, calcium is 9.9. So Glenn, what would you advise this child? This child right from the 6 months of age. Now he has undergone multiple interventions. His life is actually miserable that he is forming stones again and again. So what is your advice in this case?
Well, again, as a young stone former, starting forming stones at age 4, immediately this individual's at high risk, and you're suspecting stones like cystine stones right away as being one of the etiologies. And so, of course, if you had done, if the patient had had a stone analysis done immediately when he was 4 or 8 years old, it would be apparent that he would be a cystine stone former and would need to be on some type of medical therapy. Now, Dave Goldfarb is one of the members of the Rare Kidney Stone Consortium in the United States, and that is a consortium of investigators that are focused on rare kidney stones. And I'd really like to hear his comments on this because he has done a tremendous amount of work on patients with cystinuria.
So David, what is your advice on this child?
Yeah, this is a hard one. You know, I'm not a pediatrician, and fortunately, I've only been involved with a few children like this. I mean, the issue here, we talk about fluid intake or potassium citrate or alkali intake. You know, and Roger, Brian, and I are also recently co-authors of a consensus document regarding the treatment of cystinuria, which I hope you'll all have access to. We tried to basically review the best evidence. There's no question that increasing his fluid intake and increasing his urine pH would be the most important things to do. Currently, it's difficult around the world, outside the United States, to get access to thiopronin, Thiola, or penicillamine. It's not always available. They're ridiculously expensive for drugs that, you know, have been used for 40 years. So one possibility is whether he's able to increase fluid intake and take alkali. If not, I certainly know cases. I haven't ordered this myself, but some of you probably have more experience than me in having a tube, a gastric tube put in order to keep urine volume up and administer alkali to patients who are young. As people get older, teenagers are able to keep their fluid intake up and get better at this, and certainly be more motivated to do that. But little kids have a harder time with it.
A quick question I want to ask you is that in a pediatric age group, what is your opinion about 24 hours versus the single random sample urine for all the metabolic workup? So what is your opinion about that?
That's a good question. I mean, obviously, it's difficult to get 20 kids to do 24-hour urine collections. They're obviously hard. It's harder to get them to be able to do that. And at that point, you know, I'm pretty comfortable with the idea of cystinuria needing a high volume, and usually the parents are able to tell you what the volume is going to be. And you can certainly check urine pH once or twice a day at different times to get the pH higher. You know, my goal would be 7.5 or more. In a patient like that. So I agree that spot urine collections might be the best way to go. It's certainly reasonable to have a cystine creatinine ratio and look at that number, or a cystine, or with calcium stone formers, a calcium creatinine ratio as well.
So we did actually his metabolic workup, which did not show much this, and we put this patient on Thiola 100 milligrams this. Cystine. Basically, in India, we don't see much cystine stones. Maybe one in 5-10 years, we see the cystine stones. It's not so common at all here. And these agents are actually not available in our country. But I don't know how to interpret this, the plasma cystine. Do you do this plasma cystine anytime? So this patient underwent this plasma cystine, and 3 months later, this was 5.68 and 7.47. I don't know how to interpret this. Can you interpret on that?
No. So a plasma cystine level is something that I have no experience with it. But I will tell you one thing that's happening right now. There's a company called Iglia. I don't really have any financial relationship with them. They're developing an enzyme that degrades cysteine to the monomer cysteine, right? So 2 molecules of cysteine form 1 molecule of poorly soluble cysteine. And their enzyme is given intravenously, and it's been successful in a mouse model. It degrades cysteine to cysteine, which is soluble. And I was skeptical about that because I really wasn't sure if there was enough plasma cysteine for the enzyme to work on. But in the animal model, and this has not yet been done in humans, in the animal model, it worked. And there, the idea is that if you lower plasma cysteine levels, you'll have less cysteine in the urine. It certainly makes sense. I just wasn't sure if the cysteine levels were adequate. And that's because there are some old data, really about 40 years old or more, showing that patients with cystinuria have lower plasma cysteine levels than normal people. And that's for obvious reasons. Two important reasons. One, they're losing cysteine in the urine, so therefore their plasma cysteine is lower. 2, they have impaired cysteine absorption by the intestine because the same transporter is defective in the intestinal lumen as in the kidney. So it's not surprising to learn that patients with cystinuria have reduced plasma cysteine levels. Whether that has any clinical significance is really unknown. But this company is making that degrades cysteine in the plasma and therefore reduces the amount of cysteine in the urine. So it's interesting, as opposed to taking a pill, you'd have to have an injection periodically. Right. Nobody's quite sure what the half-life of that drug would be, but it's an interesting idea.
Right, I think so.
I just want to make one comment.
Yeah, please go ahead. Please go ahead.
Yeah. Patient, you were giving him 100 milligrams a day. For children, the dosing is 15 milligrams per kilogram per day, so it depends on his weight. But assuming he's almost an adult, your dosing is going to have to be much higher, at a minimum of 800 milligrams starting dose per day.
Okay.
And that's probably on the low end. A lot of our patients are on 1,200 milligrams.
Right.
Fortunately, in the United States, we now have a new formulary for teoprene. It's a 300 milligram tablet. I'm not sure if that's even available where you're at, but I just wanted to make that point.
Yeah, so I think cysteine is a big problem here. We, of course, lucky that we don't see much cysteine stones here, but this is how the stones is. And I think it was wonderful talking to you. This was a fantastic case discussion. And I think you have covered most of the problems which come to our mind. And I think your answers were absolutely perfect to the point, and it made it gave a lot of clarity about how to manage, how to go ahead about it. Over to you, sir. Please go ahead, Dr. Mahesh Desai, please.
Glenn, if you remember, I was after you to get me a Thiola for. This was the patient. And I managed to get from Russia. And at the moment, we are treating the child through the hospital, and but we don't have too many patients. But I wish we have somebody who can manufacture the Thiola here or supply here. There's a one question. There are many questions has come. There is all these questions are there, but I don't think much we have time. But there's a one question to Glenn. What is the incidence of RTA in carbopeptide stone?
Well, RTA, we see that mostly in younger women. Calcium phosphate stones, most likely, we're going to see because the patients with RTA cannot acidify their urine, and therefore they're going to have a very alkaline pH. And so we're more likely to see calcium phosphate stones.
Okay. David, is any role of heavy metals in kidney stone disease?
I'm not sure. Yeah, that's actually something that Marshall Stoller I associate with. Marshall has looked at the possibility that heavy metals are involved. Some studies have suggested higher levels, some lower levels. I think that's not of demonstrated clinical significance yet, but an interesting topic, Mahesh.
Yeah. One question, Brian. Once you have a recurrent stone, how long do you give potassium citrate?
Well, what I tell them, Mahesh, is that if they want lifelong stone prevention, they have to stay on the meds. So, the meds are in and out of your system, in a matter of days, right? And so, I say, if you take potassium, if you have a calcium oxalate stone and you take potassium citrate for 3 months, 6 months from now, you're going to be at the same risk as you were before you took the meds. So I say, I'm not going to be upset with them if they stop taking the meds. And frankly, at least in American culture, it is true. This is a benign disease, and many people, sort of get a period of quiet and then, frankly, become non-compliant with the meds. There's plenty of papers that have published that. But so I say, look, I want to work with you. I'll follow you. As people mentioned before, I do bring them back because, there's this concept that people feel responsible when they're in a stone clinic to comply with the stone clinic recommendations. But I tell them, if you stop the potassium citrate, a few days later, you're going to be back at your baseline.
Okay. And the last question is, of course, diet is important. And as you said, Roger, that we don't have too much time. Do you have a dietitian in your team who gives the proper advice? Because, in India, we have a northern India, which has a different diet. Southern India has a different diet. We have Gujaratis have a different diet. Bengalis have a different diet. So it is very difficult for us to prescribe a proper diet. So do you include dietitian in your team?
You have to unmute yourself.
Yes, we do have a nutritionist, and since I included a dietitian in our clinic, my use of pharmacotherapy and drugs has significantly dropped down. And I find that most patients, if they can avoid taking a drug, they'd rather try to modify their diet, at least give it a try. I'm not saying they're going to be successful, right? But I think it's something that they're motivated. Many of them, at least in our area, are motivated to try.
Okay. Well, there are more than 100 questions have come. I don't think we have a time, but I will try to select out and then probably send you few answer them. And Glenn, I cannot thank you. I thank you from the bottom of my heart that you have agreed to do this, and looking at the response and the interest people have in preventing the stone disease is tremendous. I think all of you have contributed very nicely. Everybody's stimulated, and I hope we should do it more. And because the stone disease is global, and maybe different factors plays more part in each one, but I think basically we should have a global consensus opinion and treatment plan so we can do it. Maybe Glenn Preminger Prevention Clinic can have a franchise all over the world. Thank you. Thank you so much for joining. And Glenn, you want to give your last word? But everybody give a last word.
Mahesh, thank you again. And like I said, it's just so nice to have a group of like-minded individuals and appreciate your support in pushing us to put this program together. And thanks to Roger and Brian and David for all of their support. And I think that unfortunately, as the study that Dave Goldfarb showed about only less than 10% of the patients in the U.S. getting 24-hour urines, it looks like we still have a long way to go, not only in the U.S. but across the world. So we'll keep pushing, and I like the idea. David, I'll be up in New York over the next few weeks to inaugurate the new Preminger clinic. But maybe we should make it.
Look forward to that.
David?
Great. Mahesh, you're one of the giants. I'm really privileged to have an affiliation with you. Glenn as well, one of the real giants. The two of you are magnificent, and thanks for having me today.
Thank you. Thank you, Brian. So nice to have you.
I think I'd say that perhaps the youngest guy in the panel here, it's a big charge to sort of carry the torch that people like Glenn and David and Mahesh have created in stone disease, both surgery and prevention. But I think this is the key. I think the key is continued discussion, continued meetings of people who are passionate about this disease, about the immediate cure of PCNL and ureteroscopy, as well as the long-term treatment with prevention. And I think we just need to continue the dialogue and continue to try and inspire, the people we're training on these topics. But again, of course, what an honor to be simply the last guy on the bench on this all-star team, to use an American sports quote. And I'm so glad to be here. Thank you again.
Thank you. Roger? To see
Well,
again.
I want to thank both Mahesh and Pradeep and Ravi for inviting me, but I know Glenn was the man here probably who got me in like he always does, so I have him to thank for my career. But I love the idea that it's a worldwide problem, like you said, Mahesh, and now we have a worldwide attempt to solve the problem. So let's do this again. I think this is a great idea. You got 100 more questions out there. I think there's more opportunities for us to help people. So I love it. Thanks for doing this, Mahesh.
Thank you. Thank you. Thank you on behalf of Sabnis, Pradeep, and whole MPUH team. And I hope we'll do it again. Glenn, thank you so much.
Thank you.
Thank you, Mahesh.
Bye.
Have a good evening.
Bye.
Bye.
Here.
Bye, David.
Mahesh,
Bye.
see you later.
See you later. See you later. I'll write to you, all of you.
Take care.
Thank you.